Okay, welcome everyone. And my session's going for 15 minutes at the most. And then I've got to dash off to get a plane. So I'm going to have my details on the last slide. So if you'd like to, interest in Murray Stopes Australia or anything I've spoken about today, please feel free to send me an email. So my presentation today is on healthcare planning for rural women. So before I get started, I'd like to acknowledge the traditional owners of the land on which we're gathered, the Larrakia people, and pay my respects to the past, present and emerging leaders. So I'd like to introduce you to Julie and tell you about her experience, a lived women's experience. Julie is a 30-year-old single mother with a 3-year-old daughter. She lives in a small rural town in New South Wales, and Julie has a very unsupportive partner who comes and goes as he pleases. Julie has just found out that she's pregnant. She's in the process of weighing up her options, have a termination or go ahead with the pregnancy. There's no termination of pregnancy provider in Julie's town. She doesn't know her GP's view on abortion, and the town where Julie lives lost their maternity unit just recently. For Julie, if she continues her pregnancy and has her baby in her town, her baby is 4 times more likely to die than if she gave birth in a town with a maternity unit. If Julie decides to terminate her pregnancy, she'll have to drive several hours to the nearest major centre to access the service. If she chooses to have a surgical termination, she'll need to have a support person, organise childcare and take time off work, all at her own expense. Sadly, Julie's story is reflective of the current situation of many rural women in Australia and many of those who do contact our service at Murray Stopes Australia. Being female and in a rural and remote area, Julie and her daughter have a number of healthcare challenges. Julie and her daughter will at some stage experience a mental health issue, and when they do, they'll be less likely to seek help from their GP. In fact, they will be 16% less likely to do so than their city counterparts. Julie and her daughter are 21% more likely to experience intimate partner violence than their city counterparts. Julie's daughter is up to 32 more times more likely to have a teenage pregnancy than her city counterparts. And both Julie and her daughter are 50% more likely to have ischemic heart disease than their city counterparts. I know I've painted a rather bleak picture for Julie and her daughter, but the reality is that women in rural and remote Australia face specific health issues that require national attention. Their circumstances are indicative of a much larger problem to do with our healthcare system. Last year, the Commonwealth Fund ranked Australia's universal healthcare system as one of the best in the world. In fact, it came in at number 2 out of 11 countries. However, when it came to equity of health system, we dropped to number 7 out of 11. So while we have an excellent universal healthcare system, and I've travelled a lot and worked in a lot of international healthcare systems, I still think we have one of the best in the world, and we have a long way to go to make sure that one of the best in the world is for all Australians. When it comes to healthcare planning, as well as evidence and systems thinking approach, we must use a gendered lens. This will ensure that women's health, particularly rural women's health, is providing women with access to quality care and better healthcare outcomes. It will help us to address some of the inequities in our healthcare system that specifically impact women. So let's get back to Julie and her daughter. 2 weeks ago, I was very pleased to see the Australian Government has released the draft of the National Women's Health Strategy 2020-2030. This strategy is an opportunity to bring the voices of rural and remote women and girls to the forefront of healthcare planning, not just across a life course, but across generations. The strategy has 5 areas of priority: mental health and wellbeing, chronic disease and preventative health, sexual and reproductive health, conditions where women are overrepresented, including intimate partner violence, sexual violence and eating disorders, and healthy ageing. We need to make sure that we're seeing these priority areas in the context of the lived experiences of women like Julie and her daughter. The area that I do believe is going to be the hardest to address, and the one the women like Julie and her daughter will most likely struggle, is that with sexual and reproductive health. Why? Because it's one of the most stigmatised areas of healthcare, and it's one that governments across this country are failing to prioritise. I'm glad that it's been identified as a priority area in the draft National Women's Health Plan, because there's a lot of ground to make up to help women like Julie and her daughter. Firstly, I'd like to start by looking at the abortion access for women like Julie. While many women will self-refer to abortion providers, others will ask their GP for information and assistance. In regional areas, there appears to be a higher prevalence of conscientious objection to abortion. A recent study by the University of Melbourne found that nearly 40% of rural GPs in Victoria's West held a conscientious objection to abortion, and this is considered to be more than double the national rate, although anecdotal feedback from our counsellors at Marie Stopes Australia would suggest that it's much higher. While in most states and territories it's not a requirement to have a referral from a doctor for a termination of pregnancy, we know that 39% of our patients come via a recommendation from their GP. So if Julie lives in a rural town where her GP is a conscientious objector, it's going to be difficult for her to get access to information about abortion care. Even if Julie's GP is supportive of her decision, it's likely that she will need to wait twice as long as her city counterparts to get an appointment from her GP. When a woman chooses to have an abortion, it is important that she has timely access to the service in order to decrease clinical risk and emotional stress. If Julie decides to self-refer to an abortion provider, she will still find it difficult to gain information about the service and her options. A 2015 study on abortion access barriers for women in rural New South Wales found that abortion, shame and stigma were the major blocks when it came to accessing information about services. The same study found that while these regional women kept their experiences hidden, they were surprised and comforted when they realised that many other women in their own town had gone through similar experiences. And this is the thing, abortion is not rare. 1 in 3 or 1 in 4 women will have an abortion. Yet the shame and stigma surrounding it means that women like Julie, who may choose to have one, will keep it as a guilty secret, or because of the way our society stigmatises abortion. If Julie decides to terminate her pregnancy, she also has a number of logistical hurdles. Depending on her gestation, whether she has a medical or surgical termination, Julie may need to find anywhere between $290 to $2,000 for the procedure. If she needs to travel to a clinic, she may need to drive up to 9 hours to get there. And if she has a surgical termination, she'll need to support in the form of childcare and someone who can drive her home from after the procedure. So for Julie, ending her pregnancy comes with significant barriers. She must fund the procedure, which is going to be difficult seeing as she earns considerably less than her city counterpart. Her partner is unsupportive. She needs to find someone who can care for her daughter while she has the procedure. She needs to find a support person who can drive her home from the procedure, and she's likely to take unpaid or annual leave for the procedure because she probably want to disclose to her colleagues that she is going to have a termination. If Julie decides to continue her pregnancy as a rural woman, she'll face unique barriers. In just over 2 decades, 50% of Australia's small rural maternity units have closed. These closures are due to a combination of safety and quality, workforce availability and cost. If Julie has a complicated pregnancy and requires specialist support, she will need to deliver in a hospital that is likely far from her home. She's also going to require ongoing obstetric care, and again, this will be challenging because, like most rural towns, those services are not readily available. As remoteness increases, specialist services decrease. Julie will need to travel at regular intervals throughout her pregnancy to the nearest major town centre to access these services. She'll need to take time off work to do so. She'll need to find childcare for her daughter, and she will need to pay for travel. When it comes time for the baby to arrive, if she has complications, then she may need to relocate with her daughter to be close to a maternity unit or the nearest major hospital. So if Julie chooses to continue her pregnancy, she will also have significant barriers to overcome, all while working and taking care of a young daughter. For Julie and her daughter, the challenges they face when it comes to sexual and reproductive health care will be more than access to unplanned pregnancy support. STIs are a major concern across Australia, particularly in regional remote areas. Last year, the Kirby Institute reported a 15% increase in gonorrhea notifications in regional areas and a staggering 209% increase in infectious syphilis notification rates in regional areas and 176% increase in notifications in remote areas. STI notifications across the last 5 years have shown a steady growth in young people aged 15 to 29 years. In rural areas like where Julie and her daughter live, there are barriers to STI screening and treatment. There's a lack of access to appropriate GPs, and this is because GPs are likely to be an older man, and like most young rural women, Julie's daughter will probably prefer to see a female doctor. And given that women make up less than half of rural GPs, that's going to be a challenge. If Julie's daughter does decide to go and see her local GP, she will need to wait twice as long as her city counterparts to get an appointment. Unlike her city counterpart, Julie's daughter will be more acutely aware of privacy and confidentiality, and this is a small town where people know each other well. Preventing unplanned pregnancies like the one that Julie is dealing with is also a challenge in a small rural town. However, this challenge needs to be overcome given the high rate of teenage pregnancies in rural and remote areas. Julie and her daughter will struggle to access long-acting reversible contraception through their GP. We know that Julie's daughter is up to 32 times more likely to experience a teenage pregnancy than her city counterparts. If Julie's daughter does become pregnant and decides to have the baby before she finishes school, then that will impact on the life expectancy of her child. Research shows a clear link between literacy and neonatal mortality from low weight. In fact, it shows that each year Julie's daughter stays in school, she's adding up to 4 years to the life expectancy of her first child. For Julie and her daughter, being female in a small rural town means that they will have to deal with complex and costly challenges to maintain their health and well-being. As the Australian Government consults on the development of the National Women's Health Plan, I urge them to bring to the fore the voices of rural and remote women. Their needs are different to women of urban areas. We need richer data on what rural women want for their health and well-being. Marie Stopes Australia has started to do this with abortion care and other sexual and reproductive health services. In collaboration with the National University and led by Australia's leading data scientist, epidemiologist, biostatistician, Professor Bruce Shadbolt, we've embarked on a global collaborative research program to determine what women want when it comes to sexual and reproductive health services. Initial qualitative research on what women want in abortion care has confirmed that there are differences in the needs of rural women compared to urban areas. While we need to investigate these initial findings further, I'd like to share some of them with you today. When it comes to decision making, rural women preferred over-the-phone support and interaction, as opposed to urban women who were more comfortable with web-based information. Procedure-wise, rural women were concerned with the care and compassion of staff throughout the entire continuum of care, whereas urban women were more attuned to care and compassion at the beginning and end of the procedure. Post-care, rural women were more concerned with having a supportive advocate and transport access, while urban women were more concerned with personalised transfer of knowledge. When it came to follow-up, rural women were more concerned with continued supportive care, while urban women wanted follow-up to be personalised to their needs. While this A&E research is in its early stages, I believe it will be a game changer in the way we understand and plan for women's sexual and reproductive health provision. It's an important research because it will bring to the fore the voices of women like Julie and improve sexual and reproductive health care for her and for her daughter. While research is critical to better healthcare planning for rural women, I also believe that we need to reform parts of our healthcare system and the way we deliver rural women's health. When healthcare services in rural areas are shut down, there are generally 3 reasons given: quality and safety, cost and lack of workforce. If we're to tackle these issues, we need to consider more innovative approaches to healthcare provision that address these 3 issues. These include investigating and investing in mobile health services, including surgical services, and expanding telehealth services, particularly in the sexual and reproductive health space. If we can provide abortion care over the phone, then the chances are we can provide more services. We also need to have a more responsive medical benefits scheme. We know that on average, rural women are more likely to incur out-of-pocket expenses for GP visits. Better rebates need to be available for rural communities. For women, when it comes to services such as termination of pregnancy and long-acting reversible contraception, the rebates are woeful. They discourage health practitioners from providing the services and limit women's access. And finally, we need to have a national rural women's health plan, because women in rural communities have unique needs. In a wealthy country like Australia, we need our universal healthcare system to be truly universal. It needs to bridge the health outcomes divide that exists between women in rural communities and their city counterparts. Julie and her daughter are symbolic of where we are lacking in our universal healthcare system. With political will, innovation, and listening to the voices of women like Julie and her daughter, we can bridge the health divide between our health towns and our cities. So thank you, and if you're interested in anything about Marie Stopes Australia or anything I've spoken about today, or even getting actively involved in our submissions with government, please drop me a line.